Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hi, my name is Joe Zawisza, and I'm a physician with the Pennsylvania Osteopathic Medical Association. I work as a private practice physician in internal medicine and pediatrics in Schuylkill Haven, Pennsylvania. I'm joined today by Dr. Alvin Soto-Soto, who is a resident at St. Joe's in Reading, and he's going to tell us a little bit about the work he's doing with health literacy and diabetes for the Latino population in Reading area. Dr. Soto-Soto, tell us a little bit about yourself.
Oh, well, thank you for having me. I appreciate that. I was born and raised in Puerto Rico. I did all my schooling over there, moved into Pennsylvania in 2023 when I matched into family medicine residency program here in St. Joseph Medical Center, and have since then been here. I'm currently a third year, almost done with the program, and very much looking forward to continue serving my community here in Reading and Pennsylvania. I mean, anywhere in Pennsylvania, but I'm planning to stay around for a little while.
That's great. We're glad to have you. You're just about a half hour down the road from me. Yeah. So we met a few weeks ago at a POMA function, a POMA meeting, and you were telling me about some of the work you're doing with health literacy of the Latino population for diabetes, which I thought was really neat, and it can apply to a lot of different practices, not just a specific area, but I was interested in hearing more about that. Can you tell me a little bit about what you're doing?
Sure. So we do have a heavy Latino population here. Almost 60% of the population here is Latino. And as a personal experience, we started to find out that most of our patients have a very low literacy or understanding about what diabetes is. Because of that, Dr. Rosa Gonzalez and I came up with the idea of coming up with a project that would help us to disseminate a little more knowledge about what diabetes is, specifically to our Latino patients, and trying to understand what is going on, what is their thought process behind the disease and all of that. We found out that a lot of people have very interesting misunderstandings and myths surrounding diabetes, and we're trying to find out ways to diminish those misconceptions, misunderstandings, that gap of knowledge that they don't have, which has proven a little challenging, but it has been also very interesting. We have noted that most of our patients have a very difficult time understanding the nitty-gritty details of diabetes, and they just feel like most of it is secondary to just eating high sugars or not taking their medications. And once you have insulin, you're done forever, stuff like that. Trying to find ways in which we can teach our people these are not necessarily correct or true statements, guide them a little more on what to do to improve or decreases their chances of having diabetes if they don't, or if they have, how to control them. And basically, we're trying to come up with different teaching opportunities, given the opportunity to have workshops. Either we can have small group discussions, we can have handouts like flyers or stuff like that, and tables with information, point of care, glucoses, and different health fairs or interventions like that. We can not only interact with the people, but also provide them with information and handouts like easily take home and share with other people. And also so they can see our faces and see where we're located, so we can have a retention rate, right? We can have them come back and establish care with us, and then hopefully take care of diabetes and maybe in the long run, other chronic conditions as well.
Sure. Certainly there's plenty of other things that usually go hand in hand with that. You know, it's funny because I always chuckle internally when I see a patient with diabetes, because we spend weeks learning that in medical school. Really, I mean, it's attached to every single aspect of things you do in medical school. 4 years of learning about it, and you expect your patient to be just as good at it in a 15-minute visit, and it's just not possible. And then there's, plenty of other barriers that occur. Can you tell me a little bit about some of the barriers that you run into with your patients?
I had interesting barriers here. The most common I found is the language barrier. We do make great efforts in trying to have interpreters and having these iPads for those interactions that we cannot have an in-person interpreter. But I feel like even though it's a little more challenging because of the time, right? When you have an interpreter and you have to use another person to chime in to what you're saying, it's a little more challenging to be as thorough as you can because you're short in time as well. So those are the things that I have noted as well. Personally, I have noted a lot of patients come already biased by their experiences, either personal experiences or a family history of diabetes. And most of the case, like the parents had diabetes, let's say in the 70s or 80s. And most of the patients come in talking like, oh, I don't want insulin because like I know my mom had insulin and she died, or my father had insulin and he ended up in dialysis. So I don't want any of that because that's what's going to cause me to go through the same thing. And in order for us to try to diminish that and those misconceptions, we do have to have a heavy educational component to it, right? And a 20-minute visit and sometimes even a 40-minute visit is not enough for us to do that. So I think that's when the continuity of care comes into play. But also, since we're serving a very underserved community, it's a little challenging to have them come into the office as often as we would like to, or they can't come in or no show for whatever reason, which is also another barrier I have noted in this community. So we're trying to tackle that by, instead of having them come to us, we come to them, providing them with the information that we think could be relevant and important for them to take control of their own health. And that is in combination with other projects we have going on. Like we have food as medicine. We have lifestyle interventions as well. So this is just like an adjuvant. I think that we all work together. Like it's a mixture of different projects that all go hand by hand, which is really interesting.
You already mentioned so many barriers to care that, can cross different groups. And, the Latino community is no exception to that. Language is a huge one. And that misinformation that you mentioned is a big one too. You can inherently create a lot of distrust in the physician that you're talking to. If they already have it in their head that you're going to start some therapy that they see as a negative thing. Yeah. So correcting those misconceptions is a huge thing, I'm sure.
Sometimes I start looking at everything that's out there. I went through 4 years of med school, just like you were saying, and I still don't feel like I dominate all of these. Up to date has been great at trying to understand all of that and everything. And of course, the expertise of our attendings have been playing a crucial role in this. For someone who doesn't have any medical knowledge at all, I can only imagine how overwhelming it can be.
Yeah. I'm sort of on the other end of the spectrum of what you're describing. I work in the community that I grew up in. Many of my patients knew me since I was a young kid. And, because of that, they have a level of trust in me. But I've had plenty of them that gave them a new diagnosis of diabetes and immediately their mind went to that because, like you said, grandma was on insulin and did poorly, or their uncle or somebody else, and they already think that. So if that's what happens for somebody who's in their own community they grew up in, I can only imagine, if you don't have that advantage. I know language and culture can be a big barrier too.
Talking about Reading specifically, right? We have 60% of the population being Latino itself, but I bet this happens in any other community with a different population as well. So I think it's more like something that's alarming and can be extrapolated to other areas as well, not only just Reading. And even in the speaking community as well, like diabetes is so predominant and has such a high prevalence. It is a public health problem at this point as well.
Around here, a lot of cultural diets and things that we do are based on, potatoes, starches, things like that.
Let's talk about Christmas. What about Christmas? Like these holiday seasons.
Yeah.
What do we have in our tables most of the time?
Right.
It's all carbs, mashed potatoes. We do have the pies. We do have the ice cream. Puerto Rico, almost everything is carbs. And I bet the rest of the Caribbean as well. It's always rice. And then we have the bananas. Then we have the mashed potatoes. And then we have the pastele, which is basically made out of bananas as well. Everything is carbs. And then on top of that, all of that is sweet. So it's part of the culture as well. And it's difficult for our patients to understand, come the season and they're like, well, I have to cook for my family, because it's a tradition and Thanksgiving. And then I say, well, let's try to cut off on the carbs. And they say, well, what am I going to cook then? And I offer my family, it's been challenging trying to guide our patients through the holiday season.
Yeah.
And trying for them to stay away from the carbs. So I always try to be a little more merciful and understand that by January or February, those A1Cs will be a little higher than I would want. But I try to make it a compromise with the patients. Like, I understand this is going to happen. And what are we going to do about it once the season
is done?
Because I think, we also want to preserve their mental health and their well-being in general. And then this sense of community that the holidays bring into the table is as important.
Sure. Yeah. With Thanksgiving being yesterday and the carb feast that is, and, good luck telling somebody, oh, no, you can't have, grandma's apple pie at dinner. Forget about the mashed potatoes. Do a healthier alternative. It just doesn't happen. You have that to contend against. So yeah, a lot of challenges, and it sounds like you're overcoming them, a lot of them. I think in education, we talked about that a little bit too. It's something that we fight in the exam room because, I did some research on that previously. And, they say that the average person here in America works at a second or third grade health literacy level.
Yes.
So you're not going to get very far if you're talking to them about something you learned in medical school terms, if they, just can't function at that level. So a lot of challenges.
Yeah, that's definitely a lot. That's a big barrier that we have to fight against. So we're working on it.
So do you have a way that you measure successes?
Well, to me, it's a little more challenging because I don't have that much continuity with the patients being a resident, right? And I inherited most of my patients. And now it's the third year that I have more population to see. I get to see more people, but at the same time, I get to see more of the other residents' patients. So for my own patients, I try to see them every 3 months and basically, how would I use that word? Like trend the hemoglobin A1C, I would say, and then see how it goes down, up, or if it stays the same. At this point, my goal, which I think is most of everyone's goal, is having a hemoglobin A1C under 7, but it all depends on the patients and their ages as well. I do see a very heavy elderly population as well. Like I see a very geriatric population. Most of them are 65 or older. So depending on what their age is, I try to be a little more flexible. So according to the guidelines of geriatrics as well, of course. So sometimes a good number for them is 8 instead of 7. And if the patient is 6.6, 6.7, do we really want them to keep having heavy control of their diabetes or not? They're pre-diabetic or they're diabetic, but they're doing what they can with their diet and exercising or moving around or walking. So if we have them already diagnosed with diabetes and they're on the lower end, do we really need the medications? So I think I guide myself a little more from the hemoglobin A1C side, but also patients like to talk a lot about the point of care glucoses. So we talk a little bit about that as well. And we try to, make sure like if we're fasting or anything, let's try to keep it under 200. And if we can under 100, that would be even better. But for some patients, that's detrimental. So we can't. I just ask my patients then if they don't really want to deal too much with the hemoglobin A1C or they don't understand, I try to have them get log for the diabetes, like their blood sugar logs at least once or twice a day if they're not using insulin. And then we can go over more or less how they're controlled at home. But it's definitely a challenge. I think it's more like a case-to-case situation. Like the clinic does want us to deal with the hemoglobin A1C, but for our patients, it's not always the case that we're going to be about hemoglobin A1C.
Yeah, appropriate. I think that's a great point in the fight against all chronic diseases really is, especially in a world that is expected to be more and more one size fits all, treatments and things is that we can't forget that we have to individualize things and look at the patient in front of us instead of the disease and what the textbook may say is the exact way to do things. So that's great.
We have to be flexible. Everything in medicine is trying to accommodate because that's what we have to do.
I appreciate you talking to me and congratulations to you on undertaking such a successful program, especially as a third-year resident. I know a lot of us, sometimes just struggle to get through it, but it's great the work that you're doing.
Yeah, I appreciate that. We're trying to engage as many people as we can as well. So I think it's going to be a project that will still be present even when I'm gone, because I know some other people can take over that and most likely they'll do it as gladly as I have.
Good. That's awesome. All right. Well, I appreciate you talking with me and hopefully we see more of you with POMA. Put in a little plug. I know you're an allopathic physician, but had a great time talking with you at that meeting and look forward to seeing you and more of your colleagues. So
me too. Thank you so much. I appreciate the opportunity and likewise, I hope to see you all a little more often too.
Thank you very much. Okay. Thanks for watching this episode of POMA Does podcast. I hope you all have a controlled holiday season.
Take care.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.